Yeah, thank you very much for inviting me for this meeting. And I'd be discussing something very, very basic, but probably wouldn't like to generate enough discussion on that because we know that these are two cornerstones in the management of acute coronary syndrome after an angioplasty or even with medical management. And statins, for so many years, have shown us that these are the drugs which are actually wonder molecules and must be used in each and every patient of acute coronary syndrome, irrespective of the LDL levels, irrespective of other things. And beta blockers, again, have been the cornerstones post-MI situation. Somehow or the other, what is happening in most parts of the world is that although these drugs are being used, but probably they are not being used in the proper dosages, and the guideline-directed therapy somewhere is lacking. And I think we all are responsible for that, and we must break that inertia and use these drugs to their optimal benefit. So that would be what I'll be discussing. And the best way is to start with a case. This is a 37-year-old person who is working with a corporate company, and he attended the ER with the symptoms suggestive of an acute coronary syndrome. And he is diabetic and hypertensive for 10 years. And we are seeing an epidemic of young and hypertensives and diabetics with irregular lifestyles, smoking, and dyslipidemia. He also has a strong family history of coronary artery disease, with his father having multivessel disease and undergoing CABG about 20 years back. And his lifestyle is not very good, and he frequently takes outside food at least 2 to 3 times a week. So this is the typical Indian techie which we see, and we are seeing more and more of these kind of patients. We are seeing more and more of multivessel disease. We are seeing more and more of young patients. If you look at his profile, by and large, hemodynamically, he's stable except for some tachycardia, but his hemoglobin is 11, and that is low for a male. His LDL is 168, triglycerides are 210, and his HbA1c is 8%. If you look at the medical therapy, the dose of statin for him is just 5 milligrams, and I think this is something which we need to ponder upon. And he is on a minuscule dose of metformin, and even if you look at other drugs, they are in relatively low dosages. So our prime aim here would be to evaluate this patient for dyslipidemia and actually give him the right kind of therapy, the right kind of drug, the right kind of dose. And the need for aggressive statin management in this patient is paramount because he is young, he is diabetic, he has a strong family history. So he comes in the category of at least a high risk or a very high risk individual. The other important aspect is we need to understand that whenever we use statin therapy in a patient of ACS, we are not only looking at the culprit lesion, we are looking beyond the culprit lesion. We are also looking at preventing the rupture of the vulnerable plaque. 80% of ACS patients will have more than one plaque rupture other than the culprit lesion. And we know from the IVAS studies, and this is a study which was done in 2002 and published in Circulation. And we also know that superior LDL cholesterol reduction along with plaque regression helps to achieve a significant reduction in major adverse cardiovascular and cerebrovascular events. So if the LDL level is less than 70 and the patient is on treatment with statin, he does much better when compared to a patient who has an LDL which is more than 70 and he is irregular with statins. We have seen that patients may be aggressive about statin therapy to begin with, but later on, somehow or the other, either the dosages are reduced, or they go to physicians, or they go to their treating doctors, and somehow or the other, statin therapy goes down the drain, and which is something which we really need to work upon. The guidelines over the years have clearly shown that lower the better. And in fact, the latest guidelines recommend that for secondary prevention in very high-risk individual, the kind which we are discussing in our patient case scenario, the LDL level should be below 55 milligram percent, and we must try to achieve an LDL reduction of more than 50% with a high intensity statin therapy. And we know that high intensity statin is something like rosuvastatin 40 milligram or atorvastatin 80 milligram. Most of the patients who are experiencing a second event following a first vascular event in next 2 years become very high risk or extreme risk, and in them the LDL goal has been reduced to 40 mg/cent. And if you look at the high risk individuals, the LDL goal is 70. If you look at moderate risk individuals, the goal is 100. And if you look at low risk, the goal is 116. The bottom line is try to look the risk category of your patient and try to achieve the LDL goal according to the guidelines. And in extreme risk individuals, try to achieve an LDL of around 40. This is just reiterating the same, and this slide we have come across in many conferences. This is the European Society of Cardiology 2019 guidelines, again reiterating the same which I've already mentioned. And when a patient with ACS presents to us, irrespective of his LDL level, he must receive a high-intensity statin, and this is a class 1A recommendation. And after he goes home, 4 to 6 weeks later, we must look at the lipid levels, and if they are not at goal, we might consider adding drugs like ezetimibe and now even PCSK9 inhibitors for very high-risk individuals. We also know that not only the LDL reduction, but the statins promote plaque stability, and they also have a favorable effect on the necrotic core of the vulnerable plaque. This is the yellow study which was done with rosuvastatin in picture, and this was a very interesting study which looked at multivessel disease in 87% of patients who underwent a target vessel PCI, and then the non-target lesion was assessed, and an FFR was done for that. If the FFR was less than 0.8, these patients underwent an IVUS or a near-red infrared spectroscopy, and then they were randomized into an aggressive statin therapy with rosuvastatin 40 milligram or a standard therapy in which a usual dose of statin was taken, and dual antiplatelet obviously was given for the both group of patients. And then they were followed up with a cath after 6 to 8 weeks, and the FFR, IVUS, and knees were repeated, and the patient, if he had FFR of less than 0.8, the lesion was stented and imaging was repeated. If the FFR was more than 8, the patient was treated medically. And the data was analyzed. And what was seen that there was a significant reduction in the lipid core burden index in a post-ACS patient with rosuvastatin 40 milligram. And so this is what we are seeing inside out into the coronaries. We are looking at the needs. We are looking at the lipid plaque. We are looking at the lipid core. So these drugs actually do a benefit. And somehow or the other, the cholesterol controversy comes out, and patients are confused. We are very clear on this, that these are the therapies which must be given to all patients, irrespective of their lipid levels, once they have sustained an acute coronary syndrome. The LUNA study showed that possibly the rosuvastatin has a better LDL reduction when compared to atorvastatin. And also the asteroid, by looking at the IVUS, showed that not only does this drug reduce the LDL level, it also reduces the atheroma burden, it reduces and it increases the lumen area. So in fact, the drug is working. If you look at this slide very carefully, you can easily see how the atheroma volume is decreasing over a period of 6 to 8 weeks. The asteroid also showed that the patients, when they were followed up with IVUS studies, rosuvastatin showed a significant plaque regression. Now, the question is, does the risk end here? So most of the time, the patient will come to you, has an ACS, has a stenting, is very religious with his medical therapy. But after some time, somehow or the other, the therapy is either reduced by us or the people who are treating him, and they go to multiple physicians. So the importance of continuation of therapy is very, very important. And this is the data from the PROSPECT study, which showed that both the non-culprit and culprit lesions have similar risk of recurrent events over the next 3 years. And my colleagues, you would agree with me that in last few years, we are seeing a dramatic increase in multivessel disease in young patients, and hardly we get to see type A lesions. Most of the patients have some of the plaques in the other arteries, and they come to us with recurrent events if we are sticking to one hospital. And not only the culprit lesion, but in fact, it is the non-culprit lesion, which is twice as vulnerable as compared to the culprit lesion. So your culprit lesion may be okay with stenting, but the non-culprit lesion can progress. And that is the reason these patients must achieve their LDL level according to the goals. The reduction in the carotid intermedia thickness has also been seen with the Meteor study. And the mortality benefits are maximal if the patient is adhering to the statin therapy or any therapy which is reducing the LDL level. The patient does much better when compared to a patient who is non-adherent or partially adherent. And regarding choosing the molecule, there are various molecules in the market, but possibly, wherever possible, I think the innovator must be chosen. We have seen that data with the innovator is much, much better than the generics. Coming to the second part of my presentation about the role of beta blockers, I think we are very well aware of the role of beta blockers, and we as cardiologists are using beta blockers up to the maximum. But probably with our physician colleagues, we are seeing dosage of 25 milligram or 50 milligram being prescribed for metoprolol. But when these patients actually, if you look at them, they need a guideline-directed medical therapy, should achieve a heart rate of around 60, and the maximum tolerated dose for metoprolol is around 200 milligram. If you look at the guidelines from 2012, the beta blockers, which were considered to be class 2 indications, have now clearly become class 1 indication. The second question about beta blockers is how long should we continue them? So post-MI, at least for first 6 months to 3 years, they must be continued. And there is debate on the fact that how long do we continue in a stable patient who has been revascularized. So that is again a matter of discussion which we can have at the time of discussion. If you look at the reduction in the heart rate, we know that every 10 beats per minute reduction in the heart rate dramatically reduces the cardiac death by about 30%, all-cause mortality by about 20%, sudden death by about 40%, and the non-fatal MI recurrence by about 21%. So there is just no doubt that beta blockers are excellent drugs and must form the cornerstone of therapy as early as possible after the index event. We know the mechanism of action, so I'll not go into details. Now, why metabolol? I think the reason is we have maximum data with this molecule. It is the molecule which has been existing for the longest period of time. And if you look at the data from the GMT or the Goldberg metabolol trial, it showed that there was a 36% reduction in the overall mortality, and the infarct size reduction was also significantly reduced. Although the arrhythmic mortality caused by the reduction of the PVCs, they were not decreased, but we know that sudden cardiac death and VTVF are significantly reduced by metoprolol or any other beta blocker, which is usually cardioselective. The result in about 5,000, more than 5,000 patients from 5 pooled PMI trials have shown a 42% reduction in sudden deaths, 35% reduction in ventricular reinfarction. And on an average, the drug reduces the heart rate by about 12 to 14. And as I mentioned, we must try to achieve the heart rate somewhere around 60 in most of our patients. And in some patients, you can try to achieve even up to 50 or 55, especially the young people who can tolerate the drug to this heart rate. Now, the idea again about the innovator is that you have something with Cellocan XL, which is a multi-unit pellet system technology based on the zero-order kinetics, which is probably better than the gel-based metric system. This is metoprolol succinate, which is 24-hour acting, and possibly with AstraZeneca molecule, which they have some pharmacokinetic profile of this molecule, probably this release is beneficial for the pharmacokinetics of the patients in whom we are using the drug. So it is not affected by meal, pH, or agitation. And once a daily dose is sufficient for 24 hours. It's highly selective beta-1 blockade, has less side effects. The other drug, which is cardioselective, is bisoprolol, which is as good, but the data in post-MI situation with metoprolol is highest. At a glance, the key takeaways from my talk are, we need to understand that we are having a lot of young patients, a lot of females also now coming to us with acute MI. And in fact, prevention is better than cure. One of the things which we have realized over the period of time is that if we adequately do the risk profiling of these patients and target the cholesterol levels to the guideline-directed levels, we can achieve a lot of benefits. Secondary prevention is different, but primary prevention, I think, also assumes great importance. And using beta blockers in the right dosage is very important. These two drugs after an event assume a lot of importance, but I think we must try to use these drugs wherever possible before the event happens. And using an innovator molecule probably is more beneficial when compared to a generic. Thank you so much.
Thank you very much, Dr. Samir, and thank you for sticking to time. I would request the next speaker also to restrict the talk to the designated time of 10 minutes.